So I'm so privileged to have 4 experts in type 2 diabetes sat alongside me. I started my medical career at Birmingham General Hospital, which at the time was the largest diabetic clinic in Europe. And the tragedy of type 2 diabetes was admitting every day of every week for the 6 months I was in there, people to have limbs amputated. And that really started my journey into trying to work out what to do to help these people. The sad thing is, as we've learnt from the statistics that you've seen this morning, is that far from helping it, it's just getting worse and worse and worse. And what we're trying to do today is work out how on earth can we reverse this tidal wave, absolute tidal wave of type 2 diabetes. So I've kind of divided this into various sections. So first of all, we're going to see if we can understand what's gone wrong, understanding the epidemic, which I think most of us have a good idea about. Then look at prevention strategies, how policy and public health might help, what treatment innovations there may be. I mean, we've just heard about CGMs, which are amazing. How does social determinants and inequalities come into it? And then looking forward, what new research out there is providing a ray of hope. David's always talking about hope. Hope is hugely important to how we can help address this. So first of all, team, I think we've understood the current global and regional prevalence of type 2 diabetes, which is just awful. And what trends have we observed over the last decade? Well, it's just getting worse. Does anyone want to comment on that?
Go on. I'll start. It's just so sad, isn't it? It's one of the things that drove me into this field. And it wasn't just the prevalence. It was that people are becoming younger and younger. And I'm sure when you and I qualified, type 2 diabetes was usually, it was of maturity onset.
Age onset, we call it, didn't we?
Age onset, yeah. And also, they were usually people, I don't know, would you agree, they were 65 or older?
Yep.
And that's how our practice, when I started in 1986, we didn't have many people with diabetes and they were all older. So it didn't seem like a very important disease, believe it or not. We only had 57 people with it. And now the youngest person we've got is 12 years old. And that's in my lifetime. And that's what cannot be ignored. Before long, when our generation of doctors has died out, nobody will remember a time when type 2 diabetes was rare. But this is also a hope, because if when I was younger, diabetes was rare and didn't have to be a dangerous thing for middle-aged and younger people, we could get that time back again. It's not genetic, this problem. It cannot be. It's environmental, and I'm sure one of the other speakers will be talking about that.
Brilliant. Okay, let's come on to risk factors. So what do you think are the most significant risk factors contributed to the rise in type 2 diabetes? And I'm going to give you a bit of a hint, because yesterday I was privileged enough to go to the amazing conference that Jen, your wife, ran about addiction to ultra-processed foods. And I think they may have some part to play in this. What do you think?
Yes. Yeah. I'm so sorry. Jen will never forgive me if I don't. Wonderful conference, darling. Wonderful. But yes. Why? When intelligent people do stuff that harms their health, you have to wonder about addiction, and that was what yesterday was about, and it's a really very serious problem. Sorry.
Yeah. I think we all know the standard risk factors for developing type 2 diabetes, but 2 risk factors don't get talked about often enough, and I think Gary probably uncovered some of this when he was researching the case for keto. When you were talking to all the doctors, the average doctor believes that the average patient is not really interested in improving their health. They're hesitant to talk about diet, but they're not going to do it. They're not really motivated to change how they eat. They just want a pill. They're not going to go exercise. And so I think That is one of the huge unspoken risk factors, is that the average doctor thinks either their patient's not capable or they're not motivated. And I think we've both found that's completely false. When you give people guidance that actually works, they're very interested. And then when they see it works and it continues to work, they're very motivated to continue doing that. And then the second risk factor, the reason we're seeing this epidemic of type 2 diabetes is because of the erroneous, misleading guidelines that most doctors follow. And so you've got this doctor, just imagine a GP in his surgery, his clinic, and he doubts the motivation and the competency of every single patient with type 2 diabetes. First of all, you got that. And then you're going to layer on top of that guidelines from the ADA or you're in the UK, your organization, saying, oh, let them eat whatever, it's fine, and just match that with insulin. You see, that's the perfect storm to develop an epidemic of a disease that used to be rare and prevalent only in people 65 or older. Now you've got this in 12-year-olds, 13-year-olds. And I think it's those two hidden risk factors that don't get talked about enough that played a huge role in this becoming an ageless disease. You don't have to be a certain age to have this anymore. And it's catastrophic and it's sad, but I think that its days are numbered.
Yeah, I want to add one depressing note to this. It may not be a genetic disease, and we may not be seeing this in younger and younger patients because of genes, but because of sort of epigenetics, intrauterine effects. I think many of the children and adults who suffer from this disease are basically born with an increasing predisposition for the disease because their mothers are overweight or obese or struggling with their blood sugar during pregnancy, getting the wrong dietary advice during pregnancy, so they're doing exactly the wrong thing. And so with each generation, we give birth to more and more kids who are more predisposed, who are going to get it younger and younger. And you certainly see this in the United States and populations where I live in California, where every generation, it hits younger and younger. But I think in part, it's because people are, this is a sort of effect of what's called fetal programming. And if we can't, okay. I try to imagine getting a randomized controlled trial of a ketogenic diet during pregnancy, and then following the children for 20 or 30 or 40 years to see how the disease state's going. I can't actually imagine that trial ever being done, but I would like to see it someday because I think that would go a long way to helping reverse this epidemic.
Thank you.
Thank you.
Okay, I think I'm going to direct this one at Helen because she's not said anything yet. So we're now going to prevention strategies. So how can early intervention strategies be implemented effectively to prevent the onset of type 2 diabetes?
Well, that's really unfair. I said I would do the education one. So I'm going to skip ahead and say, actually, David is the one to show it's 93% of people with pre-diabetes can reverse their condition. So it's definitely worth getting in early. But really picking up on what Ken said, our participants just love the fact that they're being told evidence-based information to help them to help their diabetes. And I put a poll on our Facebook group yesterday to see what were the main things that they really liked about TLC. And they said it is the structure of the course, the accessibility of the course, and the way that the information is being presented to them. But also it's the support, and that they really enjoy and need that support to continue beyond the end of the course. So yeah, definitely education and support is key. Thank you.
Anyone else want to talk about prevention?
I just want to support Helen. I think that the holy grail is maintenance. All sorts of things are easy to do, but to maintain it, that's the key thing. We can't just let people go. But that's also what the health service could be good at. primary care, long-term care, maintenance could sit so well in primary care, but it also sits very well. We find group work very good, WhatsApp groups, so refining what forms of ongoing support. I can't tell you, particularly after Christmas, everybody needs help after Christmas. And that's what we're thinking a lot about, is how to give effective support that can be afforded.
Brilliant. I knew you had it in there, Helen.
The other thing that I wanted to mention is I know that there's a lot of money and time going into developing apps at the moment. So if you go to the diabetes conferences or the fairs, then there's a huge number of companies springing up doing apps. And definitely they have a place because that you can access the information very easily. And for the government, it's obviously a cheap way to try and allow people access to this information. But just we really mustn't underestimate the human connection, the fact that we're social beings and that people like to actually get to know somebody that's going to help them along this journey. And I think the fact that our coaches are just so accessible really helps with the amount of support that we're able to give them. So yeah, don't convert it all to apps, please.
Okay, Ken, this is one for you, I think. The education and awareness, your new society. How are you going to help educate the American public, or indeed the public of the world? One of the things that I want to mention at this stage, I think it's amazing what you're doing. The C in public health collaboration stands for collaboration, so we stand firmly side by side with you guys, and anything we can do to help, just ask us.
So I think the key to education really moving the needle and keeping the needle moved is that it needs to be education from the top to the bottom. Because you can imagine our prototypical patient, they've watched some of my videos, they've seen Dr. Unwin's sugar guide, how many spoons of sugar in a banana. They are poison, by the way, for a diabetic. But then they go see their GP, and the GP completely poo-poos that, discounts that. It's foolishness, don't do that. You don't have to do that, right? Well, that patient got tripped up, and now they're like, well, I really like that doctor from Tennessee, and Dr. Owen is so sweet. But my GP said that was all a bunch of hokum. I don't have to do that. He gave me a new prescription, and it'll be fine. So I think we need to educate the people, the population, the patients, but we also need to educate all the dietitians and nutritionists. And the difference being that a patient gets to choose whether they accept the education or not. If you're a grown human, you get to do what you want, at least in most societies. But if you're a licensed dietitian, nutritionist, healthcare provider, you've got a higher level of duty, don't you? And so if there's something that's been proven to give the results that Dr. Unwin shows in his clinic every day, you damn well better be educating yourself on that, and you better be educating your patients on that as well, or there should be repercussions for you. And I think you'll quickly see that as the ADS starts to put out these guidelines. And then also as a dietitian or a healthcare provider, if you're like, well, I've been using the ADA guidelines for a decade now, and it's kind of anticlimactic. Not much changes when I put my patients on those guidelines, but then I started a few patients on the ADS guidelines. Lo and behold, 75% of them reversed their type 2 diabetes. My two type 1 patients now have normal A1Cs. They're using so much less insulin, so many fewer episodes of hypoglycemia. It quickly, a learned and aware and interested dietitian or doctor is going to be saying, I think I'm just going to go with the ADS for everybody. And so I think we'll see that quickly snowball into that just being the standard of care, even though whatever unknown powers that be that gave the ADA the power to set standard of care guidelines, I think that they will revoke that from them fairly quickly when everybody starts to see the results.
Thank you. Gary, is there any historical perspective on education about diabetes? Or what's been going on throughout the last 130 years?
I mean, again, the problem is the message has been the wrong message. So we educate people on keeping their cholesterol low and avoiding foods that will raise their cholesterol in theory, and that's been the dominant message of all the major health associations, first in the United States and then worldwide. I do think the key is just creating an information environment where assuming what we believe is true is correct, which it seems to be based on clinical trials and clinical experience, and if we can get everyone to get that, so if we can get mothers to realize that giving sweets and sugars to their kids are a bad mistake or a bad idea, and get them to realize that processed foods are a bad idea. And it's just people still tend to think in terms of what's the best diet, what diet should I go on, how should I eat, and then a diet, we hear this all the time, and a diet is something I can go on, I could lose the weight or get my blood sugar under control and get off it. Even when you go back 200 years to the Rollo diet, the biggest problem with implication was the doctors thought, well, great, I get people on Rollo's animal diet, their diabetes will go away, and then they could go back to eating what they used to eat, at which point they would die. But so this whole idea that just some foods really are bad for us. There's a lot of movements, like the food is medicine movement, which sounds terrific. But what you're communicating is that there are certain foods that are good for us, particularly green leafy vegetables and legumes and colorful berries. But what you're not communicating, because it's considered a negative message, is that certain foods are just bad for us and we shouldn't eat them. If we can get that part of the information environment, part of the information culture, so that everyone realizes that, and becomes, just as it's become shameful to be the person standing outside the pub smoking a cigarette, it could someday become slightly shameful to be the person standing in the pub drinking a Coke. Yeah, I don't know if we'll get there, but I think that if we do, that will begin to solve the problem. Because then everyone, it's just like everyone knows that if I eat butter, my LDL cholesterol will go up and I'll have a heart attack and die even before Dave Feldman gets to convince me otherwise. We have to get that level of information communicated on sugar, refined grains, processed foods in general. And we're making progress, certainly on sugar, but will we make enough? I don't know. Thank you.
Thanks. Moving on to policy and public health. So government policies. David, I know you've spoken to politicians of both complexions, one fairly recently, possibly the next health secretary. What do you think government policies can do to help reverse the diabetes epidemic?
I think one of the most important things is to incentivize GPs. So at the moment, I am not rewarded for my 141 cases of remission. Nobody officially even cares. The drug budget savings that I make, I'm sure the Treasury are very generous, but my practice is not allowed to keep any of those savings. If only, and I'd even say even worse than that, when we diagnose somebody with pre-diabetes, which, as I said before, 93% of those I normalize, there is no incentive at all for GPs in England to improve the blood sugar of somebody with pre-diabetes. We're paid to put you all on a register, and we're paid to maintain the register. We're not paid to do anything until we start you on metformin. That's a scandal, because it'd be so easy if only GPs were incentivized to help people with pre-diabetes. It's low-hanging fruit. My final idea, which I've shared with every health secretary I've ever managed to meet, which is 3 now. How about, this is a point about medical ethics. You know, If I remove a wart off somebody's head, they have to sign a consent form that says they understand the pros and cons of the surgical procedure they're going to undertake. However, I can give whatever drug I like to any of you for the rest of your lives with no discussion of pros and cons. And I just say, I'm just starting you on a little bit of this, you know, and here's a prescription, we'll see how it goes. I believe that there's an ethical problem with that, and that GPs should be paid to spend 20 minutes before you start somebody on lifelong medication. Give me the time. Thank you. Thank you. Give me the time to say, you know, we could start metformin today. So one of the side effects for metformin is some people get loose motions, or you may not absorb vitamins as well. Are you interested in changing your diet? Because that can make a real difference. And in 12 years, not a single patient has turned me down when I've offered them a lifestyle alternative to lifelong medication.
Okay.
Yep.
Yeah. So just thinking about policies in that, I think we need to remember we're telling people to reduce the amount of very cheap ultra-processed foods and to eat a lot of very expensive fresh foods. So the policies surely have to address the inequalities in our food environment, and we must support our British farmers because... So David said to me a while ago, you've got to get on Twitter. And I just assumed he loved Twitter. But actually, no, he doesn't like spending an hour a day on Twitter. But he realises that's how we get a movement going. And so I've been following Love British Food on Twitter. They're doing the most amazing job, and they're connecting public sector workers, so all of the people that cater in schools, in prisons, in hospitals, with the farmers, and they actually arrange visits where they go and sit around on hay bales and meet the farmers, meet the animals. And that's what we need to do, because the consumption by all of those public sector places will really get the farmers supported. So not only should we be thinking about it when we're buying for ourselves, but support Love British Food as well. Thank you.
Thank you. Following on from that, I was privileged enough to hear the great Robert Lustig yesterday, and Robert was saying, and I agree with him, that actually we need legislation in order to stem the tide of ultra-processed foods. Gary, maybe do you have a view on using legislation and health warnings and pressure to stop people eating these things?
Again, I am not a fan of government regulation, because I assume that they will. What's the technical term for screw it up? Yeah. It's just I mean I am. We have a world of people who think very differently than we are, and they'll come and take our pastrami and our butter before they'll go after sugar or refined foods. And so I think it's just a question of I would prefer education and an information culture where we know what the answer is. Everybody knows what the answer is. So if you have a child who's obese or diabetic or suffering or predisposed, the school nurse knows, the teachers know, the other students know, everybody, the insurers know, the physicians know, the dietitians know, and I'd prefer the government stay out of it. I mean, if they can do anything to help medical care, they could regulate the hell out of it as far as I'm concerned. But it makes me nervous when they come after any food product.
Gary, I agree with you, but there is one thing the government could really do. We really must stop the advertising of junk food.
Okay, let's look at healthcare systems. So how can healthcare systems be better equipped to handle and treat the vast volume of type 2 diabetics at a large scale? Ken, do you have any thoughts of that?
Well, again, the number one thing we can do is educate the public, the dietitians and the doctors, because what you're going to see is when we hit a tipping point education-wise, you're going to see the trend of type 2 diabetes flatten, and then it's going to start to decrease. And so there won't be this avalanche of diabetic patients anymore. I think until the awareness level gets to a certain point for both healthcare providers and patients, it's going to continue to go up. And there's not much you can do about that until you've got enough people educated who know that this is quite simple to fix. I think that's when you'll start to see the tide turn.
So I think education, absolutely, all for that. But also, this is a job of behaviour change, and health coaches have the expertise, they have the time, because it takes a lot of time to really understand what your problem is and what you're going to do about it. So the problem has landed with primary care when there's no need for it to stay with them. So let's leave primary care sorting out the acute medicine and supporting their patients with medication, and let's lift all of the behaviour change, the goal setting, the motivation, the just supporting people onto health coaches, who will be so much better prepared and have the time to do that properly.
Okay, let's start looking at treatment innovation. So we've heard about CGMs as a technological advancement that clearly is a game changer in terms of monitoring and more effectively treating type 2 diabetes. Is there anything else, David, you think, in terms of technical?
I've just got to mention the Freshwell app.
Of course.
Where are you? You're here, the Freshwell app. I mean, it's a brilliant thing. It's free, and it can be on all your phones, and that just makes it so easy. And on there also is, for people on a budget, that kind of thing. So I think apps are up and coming. What is it that patients want? Do you want an app? Do you want a book? Do you want a leaflet? What do you want? So just to give Freshwell a thing there. Well done, Freshwell, wherever you are. There, yes.
And I think the good thing about Freshwell, which is something that's been my passion as a medical technologist for the last 20 years, is it's actually giving the power back to the patient. For too long, we've actually locked up all of their information in these silos back in doctors' surgeries or clinics. But now they have the opportunity to actually look at their own data, curate their own data, and actually manage their own health. And I think this is massively, massively important. So data utilization, how can the data from all of these sources be used to better understand and combat the type 2 diabetes epidemic? How can we better understand what's going on in order to combat the web of misinformation that still guides a lot of the treatment?
I'll just start and then hand it over. A plea to clinicians, think about audit. Do you know in your own clinics what you're achieving? Because data is power, and in primary care we have a great deal of data, and most of us are not using it. But just simple audits can be very powerful, because then if people attack you for what you're doing, and you can say, well, on average they're losing 10 kilos in weight and I'm achieving this. So I plea for audit, please. Good idea.
I think the LDL conundrum is one of the things that will be a casualty of increasing data collection and crunching. When Dr. Unwin has somebody who's lost 10 kilos, reverse type 2 diabetes, well, he also, I think you probably record any heart attacks, strokes, things like that, right? And so when you have an increasingly large database of all these people who have put their type 2 in remission and have normal A1Cs now, he's continuing to follow them and track all that data. Well, if there is a signal of heart disease coming from the 33% who will have an elevated LDL with the diet he's recommending, we'll see that in the data, won't we? We'll see, oh, look at that spike of heart attacks in Unwin's clinic over there. That'll be patently obvious, won't it? You'll see that, and I think as of yet, you're not seeing that signal yet. So I think that's reassuring, but I think the more data we have like that, because he will be attacked at some point if he hasn't already, like, you're going to cause heart attacks in these people. What are you doing? Well, actually, the data shows very clearly, I would suspect that there's a lowered risk of acute MI in these people. And so the data will speak very clearly to that.
I think another thing is the data that we're actually collecting. I'd like to see all the surgeries making sure that they're monitoring metabolic syndrome. And so the markers that will tell you that are obviously blood glucose levels, which are heavily monitored already, blood pressure, HDL and triglycerides. But also waist measurement is such a powerful tool, and it's such a cheap and simple thing to do, but very few of the GP surgeries that I'm working with take waist measurements, and I'd like to see that sort of made standard.
I'm just thinking for anyone who has free time and is looking for a project. In the US, there's been this tremendous resource for misinformation called the National Weight Loss Registry, where basically it's at Brown University, and doctors, if you lost 40 pounds, so you went to a clinic that recommended a low-fat diet, and then you calorie restrict and lost 40 pounds, you could get yourself into this registry, and then people could look at the registry and say, well, look at all the people who lost weight on low-fat diets, so we should all eat this way. Critically flawed, but what you could do, and David raised this issue when you asked his question, how many diabetic patients, you don't get rewarded for diabetic patients who go into remission. It would be interesting to start a national registry of patients that go into remission, diabetes, drug-free remission, and how they did it, and you would just, so you could start collecting this information. So you're right that the clinical audit is vitally important, and it has to be done correctly so it's believable. But if you could start collecting the information of all the different, actually the Public Health Consortium could do this, and then you could demonstrate to other physicians that they're actually falling behind all these other medical groups. Maybe this is already in the works here, and I don't know, but if not, it's something to consider, because it's a way to demonstrate to the rest of the world that this works, and to put pressure on other people, to other physicians, other GPs to do it as well.
Wouldn't it be great, David, in our lifetime to actually see that line stop going up, level, and hopefully actually start coming down? I mean, I would feel our life work is complete when that happens. Okay, so hugely important issue that we often overlook is addressing inequalities, because the least able and the most disadvantaged in our society are most prone to the scourge of metabolic disease and type 2 diabetes. How do you think social determinants of health affect the prevalence and management of type 2 diabetes? And we'll come to a working GP, David.
One of the interesting things was as part of the audit, we looked at how do old people do compared to young people or middle-aged people. And there's good news and bad news here. We found that actually older people like me, lost more weight and improved our hemoglobin A1C better than younger people. There's an inequality there, and I think it's because younger people, maybe they're not so sure about how to cook anymore. They're busy, their lives are a bit more chaotic, or maybe they're more carb addicted, but there's an inequality there. Younger people, we're having to do demonstrations with a microwave, because some of them never use anything else but a microwave. And so there's quite a lot of work there to be done for how can younger people cook healthy food that they can afford. So it's a work stream. Somebody else.
I saw a really good thing on Twitter the other day, and it was somebody that works in the emergency room. And she was saying that she was seeing a patient who was saying, oh, my antidepressants aren't working anymore. And when she sort of dug down into what the actual problem was with this lady, it was that she was lonely, that her husband had died 10 years ago, and that she was really struggling with the loneliness. And actually she'd now ended up in this whole route of being medicalised. But we need to really recognise loneliness and the impact of loneliness on our society and just connect people together. One of the things that I love doing with our local support hubs is introducing people to others that are in a very similar situation to them and just watching them gain confidence and make friends, and doing something like this together is so much easier than trying to do it on your own.
So one of the things that I see as a clinician is the huge effect of stress on metabolic health, actually how it can overload the adrenal system. You get spikes of cortisone that really drive this disease. Do you see that, Ken? Is that something you see in your practice?
Yeah, I think every doctor sees that in their practice. Today, it's very easy to be more stressed, perhaps, than it was 2 or 3 decades ago. I've been told that by older people who were alive then. But I think that very often psychiatrists and psychologists and primary care doctors give just the most ignorant advice to people about stress. They'll say things like, "Oh, you've got to get that stress out of your life." What the hell does that even mean? Like, what you're going to just shoot your mother-in-law? That won't cause any more stress. And I think that changing the conversation, you have to learn how to manage stress. You can't murder your mother-in-law. You have to learn how to live with her. Sorry, it's true, right? And you have to learn how to cope with stress. And I think I think it's partly the fault of the pharmaceutical revolution. It's like, oh, there's a pill for that. You don't have to worry about managing or learning coping mechanisms. Maybe reading a book about stoicism and how it's okay that your life sucks. You can be happy regardless. And I think we just lost the entire plot of that with the pharmaceutical revolution. And but I think having friends and having groups and having that support, either in person or virtually, because many of us have discovered that our online friends are in fact actual real friends, even though maybe you've never met them face to face. But I do think we are social creatures, and I do think we absolutely need that support of another human being saying, "I hear you, I feel you. Yes, it sucks. I know she's a bitch, but you know, there's ways that you can cope with this."
Okay, we now come to community level interventions. And
Can I interrupt for 1 second?
Oh, absolutely, sorry.
Just to balance this, your mother-in-law is seeing a therapist who's saying the same thing about her son-in-law.
Good point, well made. I can't really top that. So coming back to how community-level interventions work, creating communities of like-minded individuals. We've been doing that for 8 years now. You guys have just started. How do you think that can help?
I think the power of it can't be overestimated. We have a private community. How many tribe members do we have here? Yeah, and so many of these people are meeting each other in person for the very first time, but we have over 8,000 members in our private community. And I can see on the back end all the interaction, the private messages, I like this post, I shared this post, I can see all that, and the level of interaction from people from every continent except Antarctica. I don't think we have any tribe members there yet. There's only a few people there. We're working on it though. But just the level of that connectedness seems amazing, and you see that with your groups online and in person as well. I think it's invaluable, and so some people need that more than others. Some people are kind of loners. They don't really need much of that, but some people really, really need that, and they feel naked without it.
Helen, do you want to say anything about community level interventions?
I think I've told you everything I've got to say. It's great.
I think one of our aims should be to normalize. So it isn't really a low carbohydrate diet that I'm on. I just think it's a normal diet. Yeah, it's a proper human diet. And I think, if we're thinking at a community level, if for a community it was normal to avoid junk food and it was normal to drink water and not squat, if we could normalize that in schools and in hospitals, that would be a great community thing to do. Thank you.
Looking forward, so future research. Clearly we've got an excellent research project underway. What are the key areas of research that need attention to effectively reverse the type 2 diabetes epidemic? So I think I'd split this into two areas. First of all, we have to dispel some still quite prevalent myths about healthcare, and then actually show that what we're proposing, what we strongly believe helps, actually works. So I think all of you must have something to say on that.
Or shall I start as I've got the mic? So what really saddens us, the health coaches are all on a WhatsApp group together, and so we're often posting participants that have done really well. And so often somebody will reverse their type 2 diabetes, they've lost a load of weight, they're feeling so much better, their energy's come back, and they'll go and see their GP, who will say, oh, but your LDL's gone up a touch, we're going to have to put you on a statin, obviously. So the research that we really need to hear is from Dave over there, because to be honest, I think that is the one thing that's holding low carb back, is that the clinicians are still really worried about LDL, and we just need to raise awareness that, well, we'll wait and see, but I think that's the main piece of research that I'm waiting for.
I'd like to see all these myths dispelled. And the only way to do it, once we moved into the evidence-based medicine movement, which began in the 1970s, both in the US and Canada and here, suddenly physicians are not going to pay attention to anything that hasn't been demonstrated unambiguously in clinical trials, so clinical evidence becomes meaningless to them because somehow somebody's told them it's just anecdotes, and on some level, we live in an evidence-based world, and the evidence is clinical trials, so we have to do clinical trials to help overturn all these beliefs, from whether or not these diets are sustainable, to whether they raise LDL cholesterol and that somehow increases your risk of heart disease, to can what David has seen in his clinic be replicated in clinics around the country? And we don't need these clinical trials on one level to demonstrate that, but people who don't experience are going to say, I haven't seen it in a clinical trial. So it would be nice to do. I mean, this is a pipe dream also, because the clinical trials are difficult, they're expensive, they can be screwed up effortlessly, and if somebody goes into it with a bias, they almost guarantee to screw it up. But on some level, I still think that's what we need to convince the world that we're not just I can't even finish that sentence. And David would like to talk.
One line of evidence and research that doesn't get talked about a lot, and Gary's right, a lot of doctors need this federal level evidence-based, or they're not going to change their practice. But you have to remember, all doctors, even your doctor, they're just dudes and chicks. There's nothing special about them. They're just folks, just people, right? And so your N=1 experiment, I know that many of you guys are hesitant to tell your doctor that you're eating a ketogenic diet or a carnivore diet or just a boring low-carb diet, right? You're hesitant to tell them that because you don't want to get yelled at by your doctor daddy. Anybody is like, yeah, I'm kind of keto on the down low, but I don't tell my doctor. And then what you don't know is a lot of doctors are also eating keto and they're not telling you. Okay? So I want you to stop being shy about telling your healthcare provider that when they say, oh, wow, you really lowered your A1C and you've lost so much weight, don't just say, yeah, I've been, following the ADA guidelines you told me to follow. Don't do that. Don't do that. Fess up. Tell your doctor, yeah, I've been eating a ketogenic diet full of real whole human foods, lots of fatty meat and low-carb vegetables. That's how I did this, because although some doctors will officially say, well, I only look at evidence-based medicine, guess what that is, folks? That's evidence right in front of the doctor's eyes, who has your chart and remembers what you used to look like and what you used to weigh, and now they're looking at you. That is the ultimate evidence. And there are many people in this room who have changed their health and changed their life, but they've also changed their doctor. And their doctor now recommends a low-carb diet to their other patients. And so don't neglect your experimentation and sharing that with your healthcare provider as well.
I wanted to say something about RCTs. Think back over the last decades. How many RCTs have there been? How much money have we spent on all of these studies? Billions and billions. And how is it going? How are we doing with obesity and type 2 diabetes? We've spent $1 trillion. How's it going? And I think it comes through university departments. They're desperate for research grants, and they're doing that. But there is another type of evidence, and that is if you take a doctor who gets results, and if those results can be replicated by like-minded doctors all over the world, that replication is a form of evidence. And I think you've already, in that way, the trouble with RCTs is you're nowhere near implementation. You've just looked at one little tiny thing, and so often RCTs fall down at the point of implementation. They don't go well. Whereas practical doctors like myself, we've already implemented it. So if I can do it, and if GPs in New Zealand can do it, and they have, and Australia, and North America, you're already well into implementation. And if it can be replicated, that is good evidence too. And I think we've had a little bit too much RCT and not quite enough audit.
Okay, and I completely agree with you. And I completely agree with Ken. So the way this happens, right, is anecdotal evidence. It begins with the patient telling a doctor that I did this and it worked, and the doctor going, oh, that's interesting, maybe I should try that. And so this would happen to all of us, right, on some level. And then, David, you've taken it to one other level with your clinical audits. Absolutely right. But we're speaking to the converted. And so yeah. And that's the issue. So and we're making progress on some level, except we're also being, there's a mostly plant, vegetarian, vegan movement that's also making progress, and we don't believe that in general they're making their patients healthier other than by improving the quality of the carbohydrates that their patients are also eating. But we don't know. And that's becoming mainstream, at least in the United States, far more quickly than this is becoming mainstream, and yet we believe that we can make people healthy and that they can. So these are the issues when you go beyond this sort of slow incremental. Like, David, I hope tomorrow I'm going to wake up and people are going to go, did you see what David Unwin did in his clinic? And he published this paper, and I'm going to do the same thing. And it's like, next thing you know, Kaiser Health in California has switched from offering their patients plant-based diets to keto, which is what they do, plant-based world in which I live. But along the way, how do we get to the masses of unconverted and convince them that there's a better way, and the only way is to compare the 2 or 3 or 4 approaches in some kind of clinical trial? And you're right, whoever does it will probably screw it up. It'll be implemented incorrectly. It'll take 10 years, and at 12 years it'll all be a wash. But I think it's the only way. It's one front. in this battle that we would benefit from approaching.
Thank you. So finally on my list, and then we'll maybe open it up to a few questions from the floor. Global collaboration. I was delighted to see at the next table to me enjoying a low-carb breakfast as some guys from Switzerland. So hello, you're out there somewhere, guys. Really good to see you here. But global collaboration, hugely important, I believe. And clearly the PHC and the ADS are going to be doing a lot of collaboration. How do you see that going, Ken?
I think transparency is the disinfectant for every governmental and official organization. There needs to be transparency or nothing at all. And so the collaboration, like I said earlier, I've already had people from several different countries reach out and say, hey, can we have a chapter here in our country? Absolutely, and we almost named it the International Diabetes Society, but I wanted it to be similar to the ADA, hoping that it would confuse people and they would go to the wrong website by accident and get the correct information. Number one. And then number two, I did it because I hope that the ADA sues us and then we can get discovery. Remember that? So either way we win. But collaboration is vital, and in the past, collaboration could sometimes take decades to filter down, especially to the lower income countries. But thanks to social media and the internet now, I think that the collaboration can be almost instantaneous, thereby saving more grandparents from early deaths and from significant debilitating disease.
Thanks. David, you've clocked up a few air miles in the last couple of years. How's it going with global collaboration for you?
Oh, I don't know what to say. It's all over the world. People are in auditoriums like this interested. It's truly international. It's truly. Last year I went to Poland, and to my astonishment there was 1,400 people in the audience. Low carb is huge in Poland. It really is spreading and spreading, and it's because it works, and things that work people notice and don't forget, and that's what's great about this. It works. People lose weight, they feel better, they tell other people, and it is already spreading fast around the world.
And I was actually at that conference in Poland with Dr. Unwin and made an egregious faux pas, which I would like to share with you. So they, proper human diet, eat your meat. And so they had just reintroduced this very rare form of Polish bison to the wild, and I just commented during my talk that would be an excellent thing to eat. Fatty ruminant mammal, right? And that didn't go off very well because evidently they don't consider those, food. So I'm sorry about that. Anybody from Poland, I apologize for my yeah, sorry.